Good morning. This is Velva Heraty broadcasting from beautiful St. Petersburg, Florida. This is going to be the final show of our series on addictions. We started with addictions from the cradle to the grave. Actually, we probably started before that with the trauma, the alcoholic family system, childhood trauma and alcoholic family systems. My companion and co-host for this series has been Dr. Jim Lewis. He's a neuropsychologist, works for the county and helping traumatized children. And he's also an expert on dementia and senior aging issues. So how we're going to wrap the show up, or the series up, we're going to talk a little bit. I'm going to encapsulate some of the things we talked about, which I'm kind of doing right now. And then we're going to pick up on our last when we talked about senior addictions and how they can be misdiagnosed by the medical community and the consequences of that, what you can do about it. Every show has solutions. If you hang in there and listen to the end of it. But we decided we weren't quite finished, so I asked Jim to do case histories of people that were misdiagnosed, and it was based on a lot of phone calls I got after the last show, people saying, well, how do I know this? How do I know that? My dad died of this. What if it was that? You know, we raised a lot of questions with the last show. So I thought if we did a couple case histories, then we could bring everybody up to it. I also want you to know that you can freely email me. It's VLH@letstalklife@gmail.com if you have any further questions, and I'll pass them along to Dr. Jim and we'll get back to you. But this will be our final show on addictions from the cradle to the grave. And we're going to segue into a clinical diagnosis and how we can sort out, how experts sort out these kinds of things. But we still stand by our original premise that the medical community is not trained to do a full and comprehensive clinical profile, because they do not do or take a comprehensive alcohol history. And I was talking to somebody today about it whose father died of dementia. And she said, you know, it's funny, Velva. Every time I went to a doctor with him, the same questions were on, the evaluations. And so we started talking about that. And I started to wonder, gee, maybe it's time for these evaluations that are carved in stone in every doctor's office we've all went to about comprehensive this. And she laughed. She says, I was asked, and I went to get a physical, and she's a senior like myself, and she was asked how many sexual partners she had. She says, I've seen that question on a lot of evaluations. She said, really, Velva? Is that? And then we talked about the common questions asked on for alcohol. How much do you drink? Do you drink every day? How many drinks per day? The same tired, ineffective questions that tell the doctor nothing at all. And we all fill them out the same way. I mean, it's a blow-off section of a medical eval, and we should really take another look at that, because had there been more robust questions like, do you take opioids? How many painkillers do you take? How many drinks do you drink? Did you ever have a blackout? The real questions about substance abuse and addictions, there might be less opioid deaths today. So I had a very robust conversation with my friend about how ancient and antiquated the medical evals are, and how the AMA really needs to sit down and modernize them so they have meaning in today's world, because they don't have meaning in today's world. So that's my first rant of the show. Before we move along, I want to thank my sponsors, UPS at 2nd and 2nd South, the all-inclusive, comprehensive service UPS that you can get just anything you possibly could want. I had my passport photo taken there last week. They're also open on Sunday, which is nice because, we all go about our business on Sundays also. So please frequent UPS on 2nd and 2nd. It's a wonderful store. And I'll tell you what's most wonderful about them is their customer service is top notch. So I urge you to go to UPS on 2nd and 2nd if you have any needs like that at all in the shipping. They have cards, they have passports, they have mailboxes if you need a mailbox. So I want to thank them for being our sponsor for the show. So here we are. I'm not going to talk much. I've been talking too much. And I think it's time now that we go right to the show, the heart of the show. First, we can answer that question. And question came up. Now, of course, I put my phone away and I don't have it in front of me. But bear with me. We'll take a quick break and we'll be right back. Okay, here we are. The question for Dr. James Lewis, who's sitting to my right today, he's going to be doing case presentations. The question is, what is the difference between the effects, we're talking about dementia now, what is the effects on dementia and between painkillers, somebody who has a history of, using painkillers, opioids, alcohol, and designer drugs? What would a doctor need to look for? So what are the differences? Jim?
Okay, thanks for having me, Velva. So a lot of times people use the term painkiller and opioids synonymously because narcotic analgesics or narcotic painkillers are opioids. And both of them have the effect of depressing the central nervous system. So they're called CNS, central nervous system depressants. Alcohol is also a central nervous system depressant. So when used together, they are causing significant central nervous system depression, which means the brain is having depressed functioning. In dementia, there's many kinds of dementia, but the question was about the caller's family member had Alzheimer's dementia. In Alzheimer's dementia, the neuron, which is the cell body, there's 100 billion neurons in the human central nervous system. In Alzheimer's disease, the neuron itself is starting to decay. Alcohol has the same effect. They're called neuronal degenerative disorders. Many years ago, and even now it's kind of making a comeback of recognizing this, it's now called alcohol-related dementia. That's what's in the medical journals now. When I was in training in the Veterans Hospital system in Washington, D.C. and then Miami in the 70s, it was called alcoholic organic brain syndrome, but it's the same thing. So essentially, if you have somebody with Alzheimer's disease and say it's a family member, suppose they're just like in the mild stage. The interesting thing about Alzheimer's dementia is in some people, the decline can be very slow. It can take 10, 15 years of decline. In other people, the decline can be very rapid. So in part of my practice in adult neurology, where I work at a facility called Central Neurology of St. Petersburg, we're trying to give advice after we evaluate the patient, give advice, well, I don't want to go deteriorate that fast. What can I do? I explain some of this to the patient and the family. Either stop drinking or significantly reduce. I mean, not more than a drink a day, and preferably not 7 days a week. So that's one possibility. But what happens is the patient comes back and says, well, I have all this pain. What's happened in the past decade for sure, since we're in the middle of an opioid crisis in our country, we've actually been in this crisis for quite a while. It's just that the politicians and journalists are starting to realize it, but it's really been ongoing for quite a while. Many pain management clinics have physicians that are trained in doing something called non-narcotic pain management. With the Alzheimer's patient who has either been drinking, using narcotic opioids to manage pain, those are not good combinations. So these doctors are using non-narcotic pain management. It can be anywhere from the anti-inflammatory drugs over-the-counter things like ibuprofen, Aleve, that sort of thing. And there's other prescription anti-inflammatories that help manage pain. So the Alzheimer's patient that's drinking and is using opioids, they're going to deteriorate. The dementia's just flat out going to deteriorate more quickly. And we talked in, I think, one of the last episodes too, what happens when you have a dementia patient who's using opioids and who's using alcohol. What does that increase the likelihood of, other than the dementia deteriorating more rapidly? Movement problems. They fall, hit their head, get a concussion. Guess what that does? Makes the dementia deteriorate even faster. So the last part of the caller's question that Velva relayed was about designer drugs. That's a difficult question to answer because these designer drugs are all totally different. We spoke in the last episode, and if you haven't heard it, it's worth listening to. These designer drugs can be anywhere from something called bath salts, which have nothing to do with the bath. There's a newer designer drug called Spice, ecstasy, things like that. Now, normally you wouldn't think of about 50, 60, and 70-year-olds using these designer drugs, but it is happening. So these designer drugs all affect the brain and nervous system differently. Some of them act like amphetamines, like speed, like uppers, stimulants, and they affect the brain that way. Those drugs can cause psychosis. They can cause paranoia. These other drugs are powerful hallucinogens. They can increase the likelihood of hallucinations and delusions. So nobody should be using designer drugs. But the caller was asking about a family member that had dementia. So that's pretty much summarizes it.
I want to ask a question here because the caller didn't ask this question. And we haven't really talked about this much. But with the advent of legalized marijuana, I think that somewhere in the show, or let's do it now, if you have any thoughts about, I know pot reduces reaction time. So in my mind, legal or not, there's going to be more automobile issues. There's going to be more issues around reaction time because it's reduced with the use of marijuana. Can you address anything about marijuana and Alzheimer's? Is there any studies out there yet?
I haven't seen studies exactly about marijuana and Alzheimer's, but here's the issue. States like Florida have passed medical marijuana laws. Other states like Colorado have recreational marijuana. What's happened is that since it's been more legalized, there are so many different strains. It's all THC, tetrahydrocannabinol, but it's all strains of THC. And what the growers are able to do, this isn't for or against, this is more scientific fact. They're able to make a strain so you could go into a medical marijuana place and say, I want a strain that's going to make me calm down and mellow because I have anxiety. Or I don't have enough energy, I'm depressed, I want a strain that's going to give me energy and give me a boost. So they all have different effects. It depends on what the strain is. Velva's mentioning the idea about driving while impaired. Pretty much every state has driving while impaired laws, DWI. Most people think it's just for alcohol, but any drug that's impairing your reflex time, your reaction time, your perception, if you're having mild hallucinogenic issues with marijuana or one of these strains of THC, you can be a distracted driver, more distracted than normal, and it can affect driving that way. But essentially, going back to the original question is, using any of these substances with a patient who has Alzheimer's dementia, it's probably not indicated at all. And you have to look at the other side of this. Patients who are being actively treated for Alzheimer's dementia normally are seeing a neurologist or at least a primary care doctor that's using medications that were developed to help. It doesn't cure Alzheimer's dementia, but helps with the memory component. And it's really two brand names, Namenda, Namenda, and Aricept, and now they're out in generic. But the question becomes, what about opiates, marijuana, other painkillers, designer drugs? What happens is they can interact. Everybody's heard the term drug interaction. All those things, marijuana included, can have a drug interaction with prescription compounds that the doctor's trying to do to manage the patient, and all these other things are interfering with it. They're either decreasing the positive effect of these drugs, or they can cause some other serious side effects, increasing blood pressure, all kinds of things like that. So the simple answer is someone with a dementia, especially somebody in the early stages, leave everything up to your doctor and stay away from alcohol if possible, and definitely stay away from these designer drugs, including so-called legal marijuana.
Okay, good, because this came to mind then as you were talking, that in our earlier show we talked about the drug swappers, the seniors that hang around these senior centers, get together, and somebody says, oh, I have this ache or pain, and somebody says, here, honey, take this, it works for me. So it's not just what the person knows they're taking, and this is all about knowing what you're putting in your body. People are often taking meds that they don't even know what's in them because their neighbors recommended them, or the woman at the bridge table recommended them, or somebody's sitting, in the senior stress class or whatever is recommending them. So you have to really start putting up a lot of walls around what you're going to put in your body, because your goal, I presume, and the goal of the people that love you is that you manage or get better. The fantasy is you'll be cured. You won't be cured. But the goal is to manage, and you can't manage it. The doctor can't manage it. You can't manage it if you're putting all these other substances in your body. It's that simple, and it's just common sense at this point.
For sure. Very fair to say. And when we get to some of these case studies, we're going to be talking about how alcohol itself can produce symptoms that start to mimic dementia, or mimic Alzheimer's dementia, and cause a lot of problems with misdiagnosis.
Well, let's go into the case studies right now.
Okay, so this has happened more than once. I practiced first up in Maryland and the D.C. area, and then for 30 years, then moved down here to Florida. And it is more commonly than you can imagine. This is the scenario. A physician asked me to do neuropsychological evaluation where I'm testing brain function, memory, attention, concentration, possible loss of IQ of a patient where there is a family member with previously diagnosed dementia. So say a 60-year-old who's becoming very concerned, I'm having forgetfulness, I'm having memory problems, and my mother or my father, or maybe more than one member of my family, had diagnosed dementia, was in a nursing home, died in a nursing home from advanced Alzheimer's disease, and I'm worried I'm getting it. So, as Velva said at the very beginning of the show, it is not uncommon, unfortunately, for the patient not to report their alcohol or so-called recreational drug abuse history. So the physician referring the patient for my evaluation doesn't know, maybe did ask, maybe the patient lied about it, does not know that the patient's actually over drinking. So I do my evaluation, I get into an interview, and I start just real simply. I do a very simple alcohol and drug history. How old were you the first time you had a drink? I never say to somebody, do you think you're an alcoholic? Do you think you're a drug addict? Even if people are, they're going to say no most of the time. Unless they're in recovery, then they'll probably admit it. But we're not talking about people in recovery. So the bottom line is this. People who are over drinking, and I believe we're going to get into later, Velva found a study, and I saw the same study myself, about what's now considered, quote, over drinking. It's astonishingly low compared to what we used to think. But so this person has been over drinking several days a week, week after week, month after month, and now they're 60. So we're talking about 20, 30, 40 years of chronic, off and on, heavy over drinking. That person is very likely to be presenting with the symptoms of this thing we talked about a minute ago, an alcohol-related dementia. They may also have Alzheimer's disease too, but it's very difficult to tell. Sometimes brain scans can tell. But the person could easily be misdiagnosed. You can have either one or both. You could have someone with Alzheimer's disease that has no alcohol abuse, memory, cognitive symptoms, etc. But you can have people with alcohol overuse for decades, and it's cumulative. The person can say, well, I'm not drinking any more now than I did 10 years ago. It's not that. It's the daily, weekly overuse of buildup of alcohol over 20, 30, and 40 years. And as we age, too, our livers are not as functionally effective, our kidneys, etc. So the more the person drinks over long periods of time, they literally start presenting with symptoms that look like the same symptoms of the beginning stages of Alzheimer's disease. So they could have that independently of having Alzheimer's disease. Or as we said a few minutes ago, you can have both. The poor patient who's showing the early stages of Alzheimer's who hasn't been told you really need to either cut down or completely quit drinking. So that is a case, but it is a common case. It isn't just one person I'm talking about. I've seen it dozens and dozens and dozens of times.
So how do you sort it out in your evaluation? The doc's referred you, he's clueless. How do you sort it out?
Well, a competent neurologist will have a brain scan. They'll see certain things on a brain scan. I'll see certain things in neuropsychological test battery. But it comes down to my conducting a careful clinical interview. We spoke last episode about truly loving family members. So a truly loving family member will come in with the patient. The patient will give me a release permission to talk to the family member, spouse, adult, child, whatever, come back, and they'll tell the truth about the family member. That can be invaluable. So say grandma's not telling the truth about how much she's drinking, but she allows her adult son or daughter to come in and talk to me, and we'll spill the beans, so to speak, and say grandma's drinking a half a bottle of wine every day, 5 days a week, or more, sometimes more. And grandma might have told me or her physician, I had, a glass of wine or two, just really undercounts.
There's never more than a glass of wine or two. We should patent that quote, because, that's the blow-off answer. And if a physician accepts that answer, or doesn't ask the obvious next question, well, how big was the glass? How many ounces were in the glass? I mean, there's so many places you can go with that question. But the physician, honestly, doesn't have the training, the education to know how to drill down to find out exactly how much alcohol is consumed on a daily basis by these people on a regular basis. So it's very tricky. They're very tricky when they answer you. And because they know they're protective of themselves, their reputation. They don't want, any medical records. There's all kinds of reasons. But you can't accept that answer. If you do, then, you're really not doing your job.
So if you have a family member that you're seeing, a senior family member that you're seeing increasing symptoms of forgetfulness, car accidents, big red flag, losing their way driving in the community, where there's a suspected neurologic problem, get that person to a competent neurologist. But if you're the one taking them and you become aware of how much they're drinking, you're not being a traitor by telling the doctor honestly what mom or dad or grandma or grandpa is actually consuming. Of course, there's the issue of releases. The patient has to get permission to speak to the doctor and so forth. But loving family members will tell the truth about what's happening with the family member, that they're worried about neurologic decline. These are neurodegenerative disorders, and they're very serious and ultimately fatal.
That's an excellent point, because on top of that point, I want to say that the loving family member has probably spent months, if not years, asking the person to cut down on their drinking or bringing the level of drinking to the attention of the person. Hey, mom, it's only 1 PM. Do you really need a drink? The interventions and the anxiety that goes along with the loving family member who begins to really have true concerns about their loved one. And you're actually, talk about stress, talk about worries, talk about fears. The next thing you know, the family member is becoming obsessed and becoming organized around this. And then you've got this whole family dynamic that shifts. And that's what a dysfunctional family looks like. So think about it. And if you're the caregiver and you're the concerned person, get yourself to Al-Anon or read some books on codependency so that you don't become part of the problem. Because it's very, very important that everybody stays focused on being part of the solution.
And so we've been talking about, up to this point, pretty much exclusively Alzheimer's disease and alcohol. But there's some cousins of these. So what else is happening with seniors? Let's say not a neurologic disorder like Alzheimer's dementia, but a senior with a psychiatric condition. One of the most common psychiatric disorders that we're seeing in our population is bipolar disorder. People have even joked, "Oh, you're acting bipolar today," whether they have the condition or not. But
that's an axis too.
Bipolar disorder. This is the connection. So we have seniors who are presenting with symptoms of bipolar disorder.
But they're not bipolar.
Well, let's talk about two of them. Let's talk about the senior who is presenting with symptoms of bipolar who are not really bipolar. What can cause them to have symptoms that mimic bipolar disorder that have to do with substance abuse? So the scenario would be this. The patient is traumatized in childhood. We've talked about that in other episodes. Starting to use drugs or alcohol to numb the psychological pain of trauma. Most of the time, they're using painkillers, opiates, stuff that numbs physical pain, numbs psychological pain. The difficulty is that it's a central nervous system depressant, so it causes the person to be down. So what does the person do then? They get a hold of Adderall or Vyvanse or their son or grandchild's Ritalin or some psychostimulant, ADHD medicine to get up again. So now they look bipolar. What does bipolar mean? You have the mania, hyperactive, overstimulated component. Then you have the depressive components, the two poles. The person with this condition, it's actually called substance-induced mood disorder, and it mimics bipolar disorder. So especially in seniors, where the doctor could be misled by the person not reporting, "Oh, I'm using alcohol, I'm using these narcotics I got when I had a dental pain, but then I've been getting them from my girlfriend who got put on oxycodone from a hip surgery, and they're using it as a painkiller to numb their psychological pain from trauma, and then turning around and using a stimulant to get back up again."
Okay, I just want a quick question here. Does this include, it's not exclusive to seniors, it can be any age?
It can be any age, yes.
Okay, that's all I need to know. Go ahead.
This can happen at any age. The older we get, though, the less resilient our brains get. So there's a term that is in neuropsychology and neurology called plasticity. The brain is very resilient. It's always trying to heal itself. When you have an injury, damage, disease, defect, the brain's trying to heal itself. At any age, you can have this substance-induced mood disorder. We're seeing it with teenagers. In my work with the Child Protection System at the Suncoast Center, we're seeing adolescents being medicated for bipolar disorder from doctors in the community when they actually have substance-induced mood disorders. But since I was focusing more on seniors, I'm glad Velva asked that. In seniors, it's even more dangerous because the seniors are taking more medicines for different conditions that they have, high blood pressure, high cholesterol, whatever. And now they're using, remember though, we're talking about bipolar, a psychiatric condition. They're using medicines or prescription drugs illicitly that are causing depression on the one end. Then they have to get back up again. They're using a psychostimulant to get back up again. Now they look like they have the upper, the manic, hypomanic component to it. So here's the catch. Velva asked me a minute ago, so are we talking about people that really don't have bipolar disorder? And I said, well, there's two scenarios. I just gave one. What's the other scenario? The person who truly has a bipolar disorder, who's medicated for it, who's doing this mess with drugs. So they're being medicated for bipolar disorder with medicines used to treat that. There's so many different medicines used to treat bipolar disorder, but they're taking prescription medicines for their bipolar disorder. And on the side, not telling their prescribing doctor, they're also abusing narcotics, marijuana, so-called designer drugs, and they make the symptoms of the bipolar disorder even worse. So they go back to the doctor and tell them what? They don't go back to the doctor and say, my bipolar medicine isn't working so well because I'm drinking and I'm using oxycodone and I'm using Ritalin to get back up again. No, they just go in and tell the doctor, my bipolar symptoms are getting worse, or a family member says, my wife or husband or father or mother's bipolar symptoms are getting worse. So
or daughters.
Or daughters. And so what's the doctor do? Increase the medicine, thinking that the medicine isn't effective enough. When in reality, the bipolar medicines are not being effective because the person is unwittingly sabotaging, unwittingly undermining the positive benefits from the actual bipolar medicines by using narcotics or recreational drugs.
And I think it's important here to just share something I learned years ago in Chicago, that a good meds doctor, a shrink who is specializing in medications, medication is an art. It's as much an art as it is a science. And it's very important and part of the struggle, and that's why there's so many blood tests in the beginning about the proper medications, is because it's an art. And doctors work very hard to give their patients the right level of medication, one that will effectively impact on the problem, but not put the person in bed with, all day in a stupor. And they work very hard on doing that. And so it's very important to honor the work of the shrink that's doing this hard work and dedicated to his patients versus the patient that's coming in and lying through their teeth and creating all this frustration and all this confusion about the real situation that the patient is in. And I can give you I'm not going to today, but I can attest to this from my days in Chicago. So he's 100% right. You have to be candid with your physician, be it a psychologist, a psychiatrist, a MD, whomever, because their task is to find the right prescription for you. And they're going on the assumption that you're not sabotaging the treatment.
Excellent point. And what's happening in our culture, Velva kind of laughingly uses the word shrink. We all know we mean psychiatrist. It's not a put down. It's just how, our culture uses that word. Here's what's happening. Psychiatrists are less often now prescribing psychiatric drugs. Primary care physicians in the past 10 years have taken over the largest volume of psychiatric drugs in the United States are being prescribed by primary care physicians. That's neither a good thing or a bad thing. It just is. Some of it's for reasons that provider unavailability. There's a lot of communities where there's too few psychiatrists, where people are waiting 4 and 6 and 8 weeks to see a psychiatrist, so the primary care doctor is prescribing the medicine. But what's the point? Most physicians that I've worked with, the vast majority, want to have this conservative philosophy that Velva just described. They want to use the lowest dose of medicine, the fewest number of medicines possible to achieve the best therapeutic benefit with the fewest side effects. And that's worth saying again. So they want to use the fewest number of medicines at the lowest dosage possible to get the maximum benefit with the fewest side effects. And as Velva points out, that is an art. Well, imagine the doctor trying to balance the scales of all these things and which medicine's going to do what. And then they're looking at the patient's blood studies. Well, they have some high cholesterol too, and they have a little high blood pressure. And the patient is unwittingly sabotaging all this by using alcohol or substances and not reporting it. So there is no physician. The doctors get bad-mouthed. I see it in the news all the time. And it's not the doctor's fault. If the patient and the family members are being dishonest, there's two forms of dishonesty. One is you come right out and tell a lie, and the other is the lie of omission, which is more common in the medical community, where the person fails to report. I mean,
or worse yet, says they had just one or two drinks.
What do we call that? Denying and minimizing. It's not uncommon. I've sat with people and I said, why didn't you tell your doctor you were drinking this much, alcohol and you were using these drugs this neighbor gave you or whatever? And they'll say, well, the doctor didn't ask me. I'm like, well, I'm sorry. You have an affirmative responsibility to report that. And I said, besides the fact that the doctor didn't ask you, I have doctors I go to. Any new doctor I go to, first thing I have to do is fill out pages of my medical history. Alcohol and drugs are on those pages.
Yeah, but they're not modernized. Like I said earlier, they're not comprehensive. There's usually just 3 or 4 questions.
Yeah, they're screening measures. And people are even fibbing on the screening measures. But it's these lies of omission. Some people will just flat out lie about it, but it's to their own demise. And anybody listening to this that has a family member, the most important thing you can get out of this is, if I can go to the doctor's visit with my family member, I want to go and I want to tell the truth because I'm going to save my family member's life.
It's that bottom line we have to look at. It's that bottom line.
You're not being disloyal. And so what is all this giving rise to? We're in St. Petersburg.
Okay. We need to take a break now because we're well into the show. And I think that's a very important next subject. So we're going to take a quick break. Jim can have a chance to take a drink of water. You can have a chance to take, a potty break. And we'll be back in a short period of time. Stay tuned. All right, we're back. I hope you've had a chance to digest some of this material. The show is very content-rich, as they all have been. So there's a lot to think about. I want you to know you can download the show on your desktop. You can play it as often as you wish. You can send it off to your family members as an attachment. The show is, in effect, your show now. You can do whatever you want with it. And then if you take it upon yourself to start educating your family system, that would be a good thing because that's how change gets made. I'm personally going to start talking to a lot of physicians I know and a lot of medical people I know. Say, hey, have you taken a look at your eval form lately? Maybe it's time to, upgrade it a little bit, modernize it, bring it into the 20th century. No, bring it into the 19th century. So that's kind of, what's coming up for me right now. But now we're going to shift a gear. I think first half of the show, the last 40 minutes, has been about sort of bringing to conclusion this whole issue about seniors and addictions and confusion and dementia and, all the problems it's creating. I think we're pretty good with that right now. So now we're going to shift into a whole other area, which Dr. Jim thinks is very important, and I do too. I was so focused on addictions, I wasn't thinking about what is normal. So he's going to talk to you now about what is normal. What is normal? There's no addictions, there's no medication abuse, meds. This is what's normal. So I'm asking him to talk to you about what are the common normal things that people have And let's talk about one of my models. I use the person and situation, because you can never remove a person from a situation. So we're going to transition from seniors and memory issues. And this is on your plate. And mention the situation some of these people are in, okay?
Right, exactly. So we've been talking about, first we started with infants and children that were drug and alcohol exposed, went up to teens, seniors. But we've been discussing almost exclusively neurologic disorders, drug and alcohol abuse disorders, disease processes like Alzheimer's disease. As I was saying a little before the break, we're broadcasting in St. Petersburg, and this is an aging community. There's a lot of young people here. There's more and more young people living in Florida now. It's the third largest state in the United States. But the biggest thing that comes up is people, especially if they have neurologic disorders in their family, a family member that had Parkinson's disease or Alzheimer's disease. And you can go off the deep end in the other direction of thinking, well, there's these symptoms that I've been having, or my spouse or loved one's been having, and I'm jumping to the conclusion is, oh my God, I had this symptom, that means I'm getting Alzheimer's dementia. So one of the things that Velva brought up in one of the past episodes, it might have been a caller or somebody who wrote in, is what do we mean when we say normal aging? What is normal aging? What are the signs of normal aging? And here's what we know. The brain has a normal loss of about 10% of volume. The total brain volume that we're born with, the total number of brain cells we're born with, there's a normal loss of brain volume of about 10% from birth until our 80s or 90s. That's without damage or disease, just normal aging. So the brain can function quite well with a 10% loss of overall volume. What are some of the symptoms that we hear about? That these symptoms can be perfectly normal for age. They can also be signs of a impending neurologic disease. But the symptoms I'm going to tell you about now, they're really not, we're calling them symptoms, but there's things that people are doing in their 20s and 30s and 40s that it's just a joke, doing the exact same thing in your 70 or 65 or 80, you think, oh my God, I must be getting dementia, right? Guess
yes,
what?
I know those people.
Okay, well, what are these things? And I'm including myself. Forgetting nouns, like looking at an object and you can't think of the name of it, or trying to, that thing I forgot, a wheelbarrow or whatever.
Forgetting people's names.
People's names, proper nouns. Forgetting nouns, proper nouns, people's names, the names of objects, is the single most common normal, quote, symptom that seniors have. Why do I say it's...
Now pay attention, all my friends, because we're all questioning our sanity at this point.
Yeah. Well, guess what? You've been doing it since you were 20 or 30, but didn't think anything of it. Now if we're 50, 60, 70, or 80, we're having it's actually called word finding. You're having trouble finding the exact word for something. One of the things that happens as we age, guess what? Our brain is only so big, we can only hold so much information. As we age, we have more nouns in our vocabulary than we did when we were 20. We know more people now than we did 20 years ago.
We know more everything.
Well, there's more things to forget, too. That's the whole bottom line. So just forgetting nouns or having a moment of word finding can be totally normal for your age and not necessarily an indicator of a neurologic disorder. So I'm going to talk to you about another very common issue. And when this comes out, the people initially are relieved and they laugh. But then they go, oh my God, I didn't even think of that. So here's a scenario. And I'm just going to say husband, wife. It can be any domestic partners. It can be, an adult child living in the home of their parent.
It could be me and my son, because he's very soft-spoken, and I am slightly hard of
Okay,
hearing.
so that's it exactly. So the person comes in and says, my husband is constantly forgetting what I'm telling him. I told him 4 times, we're going to go out with Joe and Susie on Friday at 7 o'clock, and this is the restaurant we're going to. And I talked to him about it 20 minutes later, and like we never had the conversation in the first place. What's interesting is when I go through the neuropsychological evaluation, you don't have to go through a neuropsychological evaluation to do this, but they're coming in because they're suspected of dementia. And there's these red herrings, there's these false leads that give us reason to think, well, we better take this seriously. Say this spouse that seems to be forgetting conversations had a relative, mom or dad, grandma, grandpa, who did have dementia. So, and those people had the same symptoms. So it's not stupid that you're taking it seriously. But I would say 1 in every 15 or 20 patients that I'm seeing suspected of dementia, and I go to do this auditory screening with them as part of the exam, and I find out that either left ear, right ear, or both ears have mild hearing loss. So what do we mean when we say hearing loss? Hearing loss can be, you can't hear high frequencies, low frequencies, whatever, but we're really talking about the speech sounds range. So it's really not so much hearing, it's auditory processing. We're not processing everything that someone is saying to us, especially if Joe is in one room and his spouse, Susie's in a different room, and Joe's focused on something else, and Susie says, hey, Joe, we're going to do blah, 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 and he might have picked up the conversation sometime after, hey, Joe, and didn't hear the rest of it. And he'll go, okay, honey, because he thinks he heard it all, not to just shut somebody up, or it could be the other way around. Joe's saying this and his wife is in the other room. But it's very common that I'm seeing the older person, because what is normal aging? As we age, one of the things that normally happens is our hearing can become less acute. The nerves start deteriorating, the auditory nerves start deteriorating slowly over time. We have auditory processing issues. You start turning the TV up louder. I know one of the things that I do, I turn the closed captioning because I get tired of missing what the heck they're saying. And I was joking with a friend the other day. I said, I need people to have closed captioning when they're talking to me so I could see the little words popping up on their forehead. But we're laughing about it, but it's so unnerving when the person thinks, my spouse is getting dementia when it's really a hearing difficulty. What's the solution? You go get a complete audiologic evaluation. So those are a couple of examples of what's normal aging. So this leads into, and neuropsychologists know this as well or better than anybody, and it's a little difficult to explain at first, but once you hang in there, you'll say, oh my gosh, that's exactly what's been happening to me. In our culture, we frequently use the word forgetting or forgetfulness. The older we get, we start saying, I'm getting more forgetful. Forgetting is a word that implies inability to recall, inability to remember. So let me explain how the brain works. How the brain works is, before something is stored in memory, when you're trying to recall something, it has to be stored in your memory. You can't recall something that isn't there. Okay, so what has to take place? 100% of the time, before memory occurs, what has to occur first? Attention. So if I told somebody, I'm going to say a phone number and I want you to remember it. If I say it too fast or the person's distracted, they're not going to have their attention on the phone number for a sufficiently long period of time for that phone number to get into their memory. Then the person's later going to say, oh, quote, I forgot the phone number. I'm getting forgetful. You didn't forget. Your attention wasn't on it.
Let's talk about attention for one quick second.
Sure.
Because I think we're living in a tuned out culture. There's so much stimulation that we're all tuning out. Now, one of the things I had to learn back when I was getting my certifications, clinical social work, Jungian, one of the things that was emphasized and I'm sure Jim went through the same thing, we all did, was the idea of what we called attending. Attending. And what it meant was in the clinical hour, which is a 50-minute hour, we were expected to attend. In other words, pay full attention for 50 straight minutes. And if you did that, trust me, you're exhausted. It's exhausting to pay full attention. So I would only have like three clients in a row. And then I had to take a couple hours break because I was exhausted from attending. So attending requires a lot of energy and focus. So people, because there's so many distractions, so much going on in the world today, nobody's trained to pay attention. So I started doing classes on listening skills based on the fact that, just as Jim was saying, people are too distracted. You give them a phone number, they're not even listening. They think they are. They're looking at you. They hear the words, but their mind is elsewhere. So you can help the listener by telling them how to get their mind in the room with them.
This is even more important when you realize we're talking about a topic of people thinking that they're being forgetful, and that forgetfulness is a sign that they're developing a dementia like a family member had. What Velva was describing a minute ago, we call attention fatigue or mental fatigue. When you're trying to focus on something for too long, you get attention fatigue. So here's a way to think about attention. What's the opposite of attending? Distracting, being distracted. Distractions can be external, they can be internal. So while Velva and I are going through the show here, in the background, there might be a car going down the road or somebody walking by. That could visually be a visual distraction or an auditory distraction. Velva also mentioned what other things can be distracting us. Our own thoughts. Our mind is wandering. So
our worries, our concerns,
absolutely.
Our fears. Fears are terrible distractors. And fears aren't even real. They're projections.
And this goes back to Velva's point, the person in the situation. Stress effects. Oh my God. People going through, and remember, we started doing this, we're talking about seniors. This can happen at any age. It does happen at all ages. But especially we're thinking about seniors right now, because the seniors are the ones that are going to be misdiagnosed or be overly worried that they're developing a neurologic disease when really they have something else. Stress affects attention. Stress affects the ability to remember. It affects all kinds of cognitive abilities. So a person could become more de-stressed and all of a sudden think, wow, I'm focusing better. I can think better. Well, you never had a neurologic disease in the first place. So this idea of you must pay attention before something gets into memory. So as an example, I was talking to a patient the other day who had this problem, and I found it was more attention related, and they were very relieved to know there's no signs that they were developing dementia, and what they were calling forgetfulness is really attention. They said, well, do you have it? I'm like, yeah. And I showed them in the room that I'm in. I have all these tests that I have to bring. I have my water to remember, my coffee to remember, my keys, my phone, my computer. So that morning, I'm running around the house making sure I have everything to put in the car to take up to the office. I have my keys in my hand. I set them down on the dining room table. But my mind is not attending to that I just put the keys on the dining room table. So I get everything together, I go to the car, and I go, oh my gosh, I, quote, forgot where I put my keys. I didn't forget where I put my keys. My mind wasn't attending to where I laid my keys. It didn't get into my memory. So I retraced my steps, and I could have easily made that mistake. Oh my goodness, I'm forgetful. I actually have a memory disorder. No, I don't. I didn't focus my attention on this. There's a whole cottage industry now. We get things in our emails, mindfulness. People taking nothing away from it. What is mindfulness? It's what is being called now, what Velva described that we learned 20 and 30 years ago, attending, better processes of attending. So what is the moral of this story? We wanted to draw a distinction between normal aging, so-called forgetfulness, and just that there's a lot on our attention span. We're trying to multitask our attention span like we did maybe when we were 20 or 30, and you can't do it as efficiently when you're 60 or 70. One of the interesting things that we're going to probably be doing in the next show, just to kind of give you a sneak preview, is we're going to talk about, and I'm not doing this as a tease, it's just going to take a while to do this, and we devote at least part of a show to it, how frequently seniors have adult ADHD that was never diagnosed in childhood, and now they're 50, 60, 70 years old, and they're being subjected to a full neurologic workup to see if they have dementia or something that's called pre-dementia or mild cognitive impairment, when actually they have adult ADHD. And it's going to be worth devoting. Now, that's not normal aging. That's a pre-existing condition that was never diagnosed in the first place. And it's going to be worth, spending a whole show on that.
Good, because I have to do my homework on that. And I've got a lot of anecdotal stories flying through my head, some of which I may have forgotten.
Right.
But the point is, there's a whole world out there of exploration. I used to do stress workshops years ago. I haven't done one in a long, long time. But I did them because I found out that most people suffering from stress were fear-based. And a lot of their stresses were based on fear. And I happen to know for a fact that fear is not real, that fear is always a projection of something that may happen down the road. So people are stressing themselves. And if we can get back to this focusing, and if we can tie in some ADH with fear and anxiety about a future that's yet to happen, it's about creating your own worst case scenario. And I think we could slide right into something called the inner saboteur if we really wanted to. So we're going to continue to explore these mind games. And I think one of the things we need to do is look at how we play games with our own mind. It's not about somebody else. It's not, it's about how we're tricking ourselves for many reasons into fears and beliefs and myths that aren't even real, but they're driving the decisions we make today. And the older you get, the more concerns you have. There's something that Erickson in the 8 stages of man, he calls, the life review, the generativity versus despair. And a lot of this is out of our control. And I would like to talk about, somewhere down the road, the idea of that we have so much control over our lives, when in fact we don't. And what we can control, we don't control, which is our own fears, our own reactions, and then we try to control everybody else. And that's never successful. So there's a lot to do in terms of getting your head on straight. And I think the older you get, the more important it is to keep your head on straight, because people are going to project onto you their vision of aging. And their visions are not accurate. And we have to be our own person and project our own realities and not let people. I laughed. I'm staying with a friend in Chicago I haven't seen for a while, and she wants to know if I can walk 2 flights of stairs. I said, oh my God, what does she think? And she's got an image of an aging person that can't make 2 flights of stairs. That's not in me. She's not thinking of me as a person. She's attached to an image. And this, by the way, is ageism. And when you get into ageism, you got a whole nother ballgame. And I think that's worth discussing too.
Yeah, and Velva alluded to these self-imposed stresses. All these things affect attention and memory. So that I don't leave anybody hanging, I'm going to comment that when we do our follow-up show, I'm definitely going to discuss adult ADHD, but I'm also going to not leave people hanging on what are actual signs of impending dementia. We talked about what's normal aging, what's not dementia, what's attention and not a memory disorder. And I know a lot of people are going to know, well, what do we need to be on the lookout for that is really a sign of the early onset of dementia? Because the earlier you catch the dementias, the more treatable they are, and the more we can help prolong the person's good quality of life. So I promise to be doing some of that too in one of our next shows.
Okay. Now we're going to have a show in 2 weeks, Jim and I. Or it won't be next week because I've got a person who's been listening to the show and has asked me about contributing to something called sugar addiction. And what kind of addiction is that? I mean, addiction comes in many forms. Then I found somebody else who's also interested, so we're going to do a show on sugar addiction. And that's going to be next week. And then Jim and I are going to pick up because what he's talking about requires some serious research on both our parts. And I don't know if I can do it I need a couple weeks to get, I've got a lot of case histories I can present. He's very particular about his research, and as I am, but he's got a more clinical edge to his. I'll be, so he and I will be back on the air next week. If you're into sugar and, you have to look at all kinds of things you're putting in your mouth that can become addictive. And we'll talk about that next week, sugar being one of them. Thank you for listening. Thank you, Joe, over at, I've just had a noun lapse. Over at UPS at 2nd and 2nd South. I love you, Joe. Thank you. You've got the wonderful store with fabulous customer service. And thank you for being part of this show. Okay, we'll see you next week.
Let's talk about life. Let's have a little conversation. Let's talk about life. Little love, little information. Let's talk about